it's really a pleasure to be here, and I'm really impressed at the turnout on a Wednesday night, pretty late, to talk about payment reform. So kudos to all of you, but really also kudos to Northeastern. This is just such a great program in the open classroom. I look forward to, now that I know about it, coming and listening to other people. So. I think my presentation is hopefully a good follow of Gary's, because he's so beautifully laid out the landscape of what is happening in the payment reform space, which, as he said, is really about responding to both our need to make healthcare more affordable, but also our recognition that we're really not getting the best value or bang for our buck here in the U.S., which is a pretty unfortunate situation to be in. So I thought that I would maybe take you back before I dive in. As he said, I'm going to talk about our specific payment reform program at Blue Cross of Massachusetts. It's one that we've been really transparent about. We're a nonprofit health plan. We're a mission-driven health plan. And while our job is to serve our members, we really are trying to also drive health system improvement and change, not just in this market locally, but to the extent we can be a force for driving change around interventions and things that we think can work on a broader stage. We'd like to be able to support that happening too. So I thought I'd start by maybe just talking about just a little bit about why are we talking about payment reform. We are sitting right now, as you probably know, in the state that has the, I was going to say good fortune, but that's not really right, because we worked incredibly hard to achieve this. But we have the lowest uninsurance rate in the United States, and so-called Obamacare was actually really modeled after what we were able to achieve in Massachusetts. And I was very lucky to be working with John Auerbach and others actually putting this law, implementing this law, and putting it in place. And it's quite remarkable if you look at the side of the slide in the later years, that through the recession we were able to sustain such a low uninsurance rate. So that's a way in which something I think we can be really proud of in Massachusetts. But we have this obvious distinction. You right now, sitting in this auditorium, are sitting in the city and the state that spends more per person on healthcare, and then not just anywhere in the U.S., but given the data that you saw earlier from Gary, anywhere in the world. And that means that while we have the great distinction of having the lowest uninsurance rate, and we were, I think, uniquely positioned to be able to do that, I think we actually have one of the biggest challenges when it comes to healthcare costs. And I'll talk a little bit, if you want, or we can talk about it in Q&A about why that is. So this just maps out. Massachusetts is the red line at the top, so we cost more here than in the U.S. So I don't know. There may be some people who are proud of that, but I don't count myself. I don't count myself among them. And though our health reform law in Massachusetts, which was really a law focused on improving access to health care, it was focused on getting health coverage to as many people as we could, because we knew one of the steps to getting access to care is, often, it's not having coverage. But clearly, part of our goal of getting people health insurance coverage was about helping them afford seeing physicians, getting into hospitals when they needed to. And so the good news is our health reform law has helped. So when you look at this chart, you see on the left side, the blue bar is the period before health reform in 2006, and the gray bar, and this is from a tracking study that's done by the Urban Institute, and the most recent data for this I have up here is 2010. So you can see that we made significant progress, almost cut the rate in half of families who reported having out-of-pocket spending on healthcare at above 10% of their family income, of their take-home pay. So we cut that in half. That was one of our goals. That was great news when we saw this data. However, when you look at the bars to the right, you see that we didn't make that much progress actually in reducing the number of people who reported having problems paying medical bills, and actually saw a very, very slight, this isn't really statistical, but increase in the number of people who reported having medical debt. So this just suggests, despite our progress, we still have a long way to go. And Gary put this slide up earlier. Here's just a local view. So the big bars show personal health care expenses. So you can see how much they've grown over the last 10 years in nearly doubling. So this is per person healthcare spending. But the line on this chart is actually the median household income in Massachusetts, which is pretty close to flat over the same time period. So whether you're covered or not, healthcare is consuming a greater and greater portion of just the average person's take-home pay and their budget. And that's really unsustainable. And so that's not just a problem for all of us and all the other residents in Massachusetts. It also is creating incredible pressure on state government resources. So while financing our health reform law is something that we were able to do and we remain committed to, and frankly was a relatively affordable investment relative to what we were spending on healthcare in the state to begin with, because we pay for a lot more than that. We pay for our broader Medicaid program that existed before we implemented health reform in Massachusetts. We pay for the coverage of state employees and retired state employees. If you look at the far end of this graph, the blue bar is fiscal year 2001, and kind of red-orange bars are fiscal year 2011. You see over that 10-year period, spending on healthcare, the far left, so the Medicaid program, health reform, and employee health insurance costs, employee health insurance costs went up 60% over that period. And if you look at all the bars to the right, everything else that state government spends money on, you see that cumulatively over that same time period, they dropped 20%. And John knows all too well, public health dropped almost 40% over that period. And so there's actually just a great irony here and incredible imbalance that I think is also really driving this conversation about payment reform, because there's been just reams of research that have shown us that in fact it's those things on the right side of this chart that actually have a much bigger impact on the health of the community, the so-called social determinants of health, access to education, to healthy, clean water and food and affordable housing. It's all of those other things that actually have a bigger impact on the health of the community than the health care you get in the healthcare system. And so this is a problem, and a pretty profound problem that we need to address. And when we ask, this is a tracking survey when I was at the Blue Cross Foundation that we funded, and we went out in 2011 and did a poll of residents of the state and said, so tell us about various healthcare issues, whether you think they are a crisis, a major problem, a minor problem, or not a problem in the state of Massachusetts. And the number one issue they identified was the high cost of healthcare, and 80% nearly thought that it was either an absolute crisis or a major problem. So people are experiencing this, and it shouldn't be any surprise given the data that I just put in front of you. So we knew, frankly, that when we passed our coverage reform law in Massachusetts in 2006, we kind of punted on costs. And that was an explicit decision. We knew that we'd have to come back around to dealing with the affordability and the cost of healthcare at some point. But frankly, and I think the former head of Partners healthcare system, who has since passed away, Jim Mongan, said it best in a debate that I was fortunate enough to watch when he was running Partners and Bill Van Fossen was running Blue Cross. And Jim said, we've been holding the making progress on coverage hostage to the issue of how do we make progress on costs for too many decades, and let's just do it. And frankly, solving the coverage problem, as hard as it was, and I mean, you just look at the national debt, effectively almost defaulted on our federal debt today, almost, really because of Obamacare. And yet I'm telling you that solving the problem of expanding coverage is easy relative to the problem of solving the issue of how do we make healthcare more affordable. And that's saying something. But at the end of the day, if you think about it, so when you're working on coverage, what are you working on? Well, you know what outcome you're trying to achieve, right? You're trying to get people health insurance cards that get them access to the healthcare system. And your problem is, it's a financing problem. You're really trying to figure out how do you finance the cost of that coverage. But when we're talking about the issue of healthcare affordability, we are talking about a fifth of our economy and changing the way funds flow through a fifth of the U.S. economy. It's really an incredible, I think, an incredible challenge. And when you're not talking about spending more and having that grow faster than the growth rate of the overall inflation, you're constraining resources, and you're really talking about a reallocation winners, and that means losers. And it is often the parts of the system that financially are making out best right now, where we're trying to reallocate resources from, and getting it to the parts of the system that aren't as well financed right now. Well, if you're the part that's doing really well right now, that's probably not a very comfortable conversation to be participating in. And that fundamentally is really what this payment reform conversation is about. So we've passed, since we passed our 2006 law, we've passed 3 other laws that were focused on healthcare costs, and a feature throughout all of them was payment reform. So when you heard in the intro in my background, our first law created a special commission on payment reform, and it was kind of a debate before its time. But back in 2009, we unanimously recommended in Massachusetts that we move away from fee-for-service, as Gary described. And what we unanimously recommended, and this was a commission that had the head of the Hospital Association, the president-elect of the Medical Society, the co-chairs of the Healthcare Financing Committee and the state government. It had 2 different health plans represented. And we unanimously said we need to stop paying fee-for-service and we need to move to global payments. As I said, it was a little, I think, prescient. The slide that I just flipped by was actually showing when the Commonwealth Fund went out and asked policy leaders, what strategies did they think would be the most effective for improving U.S. health system performance, and that means both improving quality and reducing costs. You actually see that the top 2, and then if you go down to the number 4, they were really all around payment reform and changing financial incentives. So there's just broad agreement in the policy community that, like it or not, financing, the financial incentives are incredibly powerful, and we need to change them. So I just kind of alluded to the payment system from 2009 recommendations was to move from this fee-for-service system where we pay everyone separately. I mean, how many of you have had the experience where you go see your primary care doctor, they do a blood draw and test for something, they identify an issue, and they say, you know what, you need to go see a specialist for follow-up. They send you to the specialist, and they do the same test again. How many of you have had this experience in your life? A lot. Well, why do we have that experience? We know that's inefficient. Wouldn't it be a heck of a lot easier to email the test results over or pick up the phone and get them? Well, I would venture to say the reason that doesn't happen is purely because we don't pay for that. We don't pay for it. But what we do pay for in our system right now is doing the test again. So, at the end of the day, like it or not, we're all in a business environment where you respond to financial incentives. And if you're going to also make a little bit of a margin on doing that test again, you do it. I don't blame anybody. So we recommended moving toward global payments, and that's really what our alternative quality contract at Blue Cross is around, where it is for let's just pretend you are a large physician group. You have patients who've chosen you as their primary care physician, and what essentially we were recommending is for all of those patients, those physicians, or they could be part of a hospital group, they could not, we were kind of agnostic about this, but would essentially take responsibility. They'd be given a payment that would represent all of the resources that were needed to take care of that patient population over a particular period of time, over a year. And they would be responsible for managing that group of patients' care. And it would remove all of the historic barriers that were posed by insurance companies who made the decisions about, we are going to pay for email, or we're not going to pay for email. And essentially just says to these groups of providers, you know what, you figure it out. You think the best thing to do is to send a pharmacist to someone's house who's just been discharged from the hospital and has gone home with 10 meds, really needs support for their family to figure out how to manage them? Fine, you do that. We're going to take away the constraints of what we cover and what we don't cover. Really leave it up to you, providers, hospitals, home health agencies, working together as a team to figure out how do you best allocate those resources. So that was the logic. As I said, we unanimously agreed to that. So at the same time that was all going on, so that was in 2009, Blue Cross, I actually left in 2007 to go be a part of the Patrick administration, but we're having these same conversations internally and realizing that we needed to change our financial incentives. and worked on developing a global payment model that starting in January 2009, we started rolling out to physician groups and hospitals. And I laugh a little bit now because you can imagine in 2009 why we picked this name, the alternative quality contract. It's because nobody was paid this way. We now, and I'll show you some slides really quickly, but have almost 90% of our physicians, our primary care physicians, our specialist physicians, and almost that amount of our HMO members in this model. So it's not feeling really alternative anymore, but you're going to see AQC a lot in my slides. At that point, the acronym had kind of stuck, so we didn't change it. But in any case, I'm just going to tell you a little bit about the AQC model. So we've talked enough about the basic parameters of it, but it's essentially we negotiate over a 5-year period. These are 5-year contracts, a global budget. So we know for whoever we're negotiating with, because we only do this in our HMO products. So those are products where people have picked a primary care physician. So we know who you have a relationship with if you're an HMO member. I am. I'm actually in this model, as are my kids. And we set a global budget. We can look back and see historically what that group of patients has cost. We know a lot about their relative health and therefore risk profile. And we negotiate with these providers a 5-year global budget target. And we are attempting, given what I showed you about that spending trajectory, to do that with more modest inflationary increases year over year than what they might have gotten historically. And we're coupling that then with, and I'll talk about this in more detail in a minute, a robust set of quality measures. So the notion is you only do well financially if you achieve good outcomes on behalf of your patients. And if you do that, and that relates to things like reducing readmissions, if you're able to successfully keep your patients out of the emergency department and keep them from being re-hospitalized after you've sent them home, a lot of those savings stay with the providers. So there's actually a real financial incentive for providers to hit all of those quality targets, which benefit not only them financially, but benefit their patients in terms of quality. So I'm not going to go into this in too much detail, but just to say, there are 60 different quality measures. They include both measures of outpatient quality and inpatient quality. They are both clinical process measures, so screenings, and for example, how many women aged 69 receive mammograms every 2 years. So as Gary said, we picked these really based on the clinical evidence, on measures that were developed by specialty societies that really follow where there's consensus around this is the care that folks should get. So there are process measures, but there are also outcome measures. So there, for instance, we look at how many surgery patients develop pneumonia after their surgery. So we're really measuring, how did people actually do, not just did they get the care that they were meant to receive. And then importantly, we also include patient experience measures. So this is where, we really ask patients, do you believe that your providers communicated well with you? And all of these things, there are different weights for different measures, but all of these things go into that last category that I described in the financial incentives around, we pay for quality. And that's because we want to make sure that not only are providers controlling costs by doing more of the things that we know work, but we also want to make sure that they're not withholding care that people need. And that was sort of some of the backlash against managed care if you go back 15 or 20 years ago. So this is really an incredibly important aspect of our global payment program. The other thing I just want to talk about a little bit, because it's another thing if you've heard about this, you might wonder about, which is, okay, so if you're creating more accountability and creating more kind of financial, quote, risk on the providers, right? You're giving them this bucket of money to manage all the care that their patients need. You might wonder, well, how much of that can you predict? How much of that can you really reliably, even if you knew what that patient population looked like a year ago or 2 years ago, stuff happens. We all know stuff happens. People get hit by cars, sadly, or get cancer, and not all of these things are predictable. So a really important distinction in how we approach these contracts and our role relative to the role of the providers that we're doing this with risk should be ours, Blue Crosses and health insurance companies. It should not be pushed on to providers. We want them accountable for really this incentive risk and only around performance and the things that are controllable, predictable, manageable, and not the things that aren't. And there is both, upside risk, so we reward them when we do well, but again, to really motivate them, and I think in anticipation of some of the criticism of smaller and more modest pay-for-performance programs, there is some downside risk here too, because that's we found that's a pretty motivating factor. So as I mentioned this already, we now have literally almost all of our network in Massachusetts now in this payment model. Early on, I think it was a harder sell for us. But as you look at just the rapid adoption, we started having people, really knock on our door and say, I want to be in this model too. And so just to give you a little bit of a flavor, this is folks all across the state, ranging from, Partners, Mass General, and Brigham and Women's, to UMass out in Worcester, Lowell General, Cooley Dickinson, way out in the westernmost part of the state. So it's really folks all over the state. And my kids are patients at Atrius Health, which was an early adopter of this model. So what are the results? The results are actually wild. Gary's right. It is still relatively early. We started this in 2009. But we opened our books up. As I said, we're a mission-driven plan that's trying to really change care and improve value, not just for our members, but are really trying to support community learning. So we opened our books up, and the Commonwealth Fund Foundation, an independent foundation in New York, and funded researchers at Harvard Medical School and Brandeis to really look at, and we welcomed them in and shared everything with them, the quality data, the cost data, to help us really assess, how's this working? And their work has been published in Health Affairs, the Journal of the American Medical Association, and the New England Journal, which, as all of you know, those publications, you don't get in there unless these are really rigorous analyses. And the conclusions have been that even in these early years, spending in the groups that were in these contracts were almost 2% lower in the first year and almost 3.5% lower in the second year compared to groups that weren't in this payment model. And quality is improving dramatically. And I have to tell you, actually, much more dramatically than we'd expected. We actually had to readjust some of the quality targets for folks because they just knocked it out of the park in the first couple of years. So that's that is really exciting and great news. And then the most recent study that was just published analyzing the APC actually also found that the benefits largely roll over to non-Blue Cross patients, because we know often physicians don't they don't look at your insurance card once you're in the examining room. So we're really actually proud of the transformative effect that this is having on the healthcare system beyond just our members. It's really fundamentally changing how these physicians practice. Quickly, just to highlight a couple of examples, and I'm just going to talk about the left side of some of the impact that it's having, for instance, on reducing emergency department use. We're seeing providers do things like having case managers make outreach calls to members who've been to the emergency department. Providers are creating new emergency department registries so that primary care providers get notified the next day if their patients have been in the emergency department. We're seeing folks opening urgent care centers and extending their hours to keep their patients out of the emergency room. I mean, wouldn't that be a dream? I remember having a 6-month-old baby and going to see my PCP at 10 minutes before 5 and having them send me to the emergency department when I knew she had an ear infection. And I just wanted to know, is this one I need to treat or not? And then spent 3 or 4 hours waiting. And revamping the availability of same-day appointments. So this may sound like no-brainers to you. This wasn't happening in our healthcare system. So this is exactly what we want to see happen. And you can see why this both has a positive impact on cost, it has a positive impact on quality, but frankly, it just makes all of us happier. Providers, the feedback that we're getting, as I just showed you from that rapid uptake of enrollment, because we're negotiating these voluntary hearing from providers, and these are just a couple of quotes, has been really positive. So it really requires sweeping changes in the culture of most of these physician organizations, including changes in roles and responsibilities. I mean, a lot of these groups are really starting to have conversations about, should you have more things being done by physician's assistants and nurse practitioners and freeing physician time up for things that really only they can do. And what we're hearing from the groups is that this culture change is not only improving patient care, but it's actually also improving physician satisfaction. That the physicians who are practicing in this new model are liking their jobs more, which is fantastic news. So I won't read you the quotes. And we're hearing the same thing from our members. So patient experience, as I mentioned, is really an important gauge of how our members are being treated by the doctors and hospitals that care for them. And we regularly go out and ask our members, does your doctor communicate well with you? Does the doctor understand your health history? When you see a specialist, how informed is your doctor about the results of that visit and the follow-up? And how easy is it for you to get a doctor's appointment when you need one? And so those patient experience scores, which are an amalgam, a compilation of the answers to all of their questions, have increased both among that 2009 and 2010 group that I mentioned being evaluated by researchers, which is fantastic. It means that not only are members consistently receiving evidence-based care that meets the level of quality we want, but they're feeling more respected and they're feeling more cared for by their physicians. So what more could we want? And the success really, this isn't by accident. In addition to the design of the model, we've invested a lot in supporting the providers in this model, and we have a 4-pronged support model. We give them data that allows them to understand their performance and understand their performance relative to their peers, data that, believe it or not, providers haven't really had before. We offer consultative support where that's useful and that's something they want. We have a dedicated team of a physician and performance improvement specialist, Blue Cross, that we make available to them. We actually bring all of these provider groups together and actually create support groups where they can share learning, whether it's physician groups or hospital leaders. And then we have a whole other suite of training and tools and communication support. And then the last thought I wanted to leave you with is this has been a meeting that's really been about how we pay. It's been about the mechanics of the methodology of how we pay providers and how do we change the financial incentives to make that methodology better and provide the right incentives for efficient and high quality care. But when we think about that goal that is both about quality but also about cost, it's not just how we pay that matters, it's also how much we pay. And this is data that I'm putting up. It's actually Blue Cross data, but it's Blue Cross data that we gave to the Attorney General, and she provided as a part of the requirements under our healthcare cost law. There have been laws. There have been a whole series of hearings every year. They're really about holding the whole system's feet to the fire and asking us a lot of tough and appropriate questions about how do we make the system more efficient. But what this shows is when you think about what drives per-person healthcare spending, there are really 3 things. There's the price of what we pay, and how does that price for doing the same thing change one year after the other. Another component is just, what are we getting? What's the mix of services? Are we getting more MRIs than X-rays from year to year? Are we getting more intensive services? And then the last thing is just how much do we get? Are we just getting more stuff? Are we seeing more doctors? Are we having more hospitalizations? And what this chart really shows you is if you look at the bottom, that's price. And what this really says is if you look at, for us, this period of 04 to 08, over that 4-year period, or 5-year period, the way this was measured, that more than half of the increase in spending year over year was pure price. It was just paying more year over year for the same things. So that's where how we pay, which really gets at more of the provider mix and service mix and utilization, the number of visits, really matters. But a huge part of this equation is also just purely how much we pay. And so we're having a very active debate about how to best balance the way the market works as it relates to how we pay. Our most recent healthcare cost laws created a whole new health policy commission that's asking really tough questions and monitoring changes in the market. And I don't think you can wake up any day or in Massachusetts where you don't see some news of some new acquisition or merger in the delivery system. Physician groups buying other physician groups, hospitals buying physician groups buying home health agencies. We're seeing an incredible amount of consolidation, and there's a level at which we want that. If we want a system that is better coordinated, it's often a lot easier to do that when you're co-located and you're working more closely and in partnership together. But I think it really does provoke some questions around, we live in a state in which that issue of how much do we pay is negotiated between payers, whether you're a government agency or whether you're Blue Cross or Tufts or Harvard Pilgrim, and the providers that we're buying services on behalf of our members from. And there's been more and more evidence and studies that have suggested when you see more consolidation, it drives prices up, not down. That even if the intent is to actually, that consolidation is probably being driven by this push for payment reform, this is something we're really going to have to keep a close eye on moving forward and make sure that we do have the right balance of leverage on the part of the people buying healthcare and leverage on the part of the healthcare delivery system that's supplying it. And I just leave you with that by saying watch, because the debate that is going on in Massachusetts about what's the right balance of the role of the market and the role of government as it relates to both how we pay and what we pay is playing out in this state in much the same way we saw coverage reform foreshadowed the national debate by about 6 or 8 years. We passed our law in 2006 and started implementing it immediately. Coverage provisions are just kicking in the Affordable Care Act right now. But once you get all those people covered, I guarantee you that the level of conversation that we're having about the cost of care, we're already having it as it relates to the Medicare program as we start anticipating boomers aging in. But once we have all of those people really covered, I think we're going to see a whole new level of debate about the cost of the U.S. healthcare system. That's going to look a lot like the debate that we're having locally in Massachusetts. But I continue to be optimistic that in the same way we led the nation with solutions to how do you solve one seemingly intractable problem, the problem of how to get coverage